Let's talk about intravenous therapy. There's different things. We have crystalloids, which is fluids, and we have colloids, which is blood products. So we're going to talk about crystalloids right now. So there are three different kinds of fluids we can give, and it's so important that you understand this. There's isotonic, hypotonic, and hypertonic. So let's start with isotonic. Isotonic, when you hear isotonic, I want you to think equal. And the reason why is because there's a proper balance, and it's not going to cause an osmotic pull. It's not going to pull anything into the vessel or pull anything out. It just keeps fluid inside the blood vessel. So our isotonic fluids are normal saline, which is 0.9%. D5W, and when you're giving dextrose, 5% dextrose in water, I want you to understand that when I hang that bag of D5W, it's isotonic. But once it's in the body, the dextrose will get used up for energy, the sugar will, and then it's just water. And so it becomes a hypotonic solution inside the body. But for testing, for understanding, what is an isotonic solution that I'm going to grab off the shelf? Normal saline, 0.9%, D5W, and the other one is LR, or lactated ringers. The thing that I want you to know about lactated ringers is it contains potassium. So if you have a patient or client that has high potassium, hyperkalemia, we don't want to give LR. With any chronic renal patients, acute renal patients, anybody with an elevated potassium level, LR is not the fluid of choice. Also, lactated ringers, if you have any liver issues, liver disease or liver failure, no lactated ringers because the liver cannot metabolize the lactate. So that becomes a problem. So that is our isotonic solution, equal. The next solution that I want to talk about is hypotonic solution. And most lectures you're going to hear hypo, hippo. And I actually like that. I love hippos. They're cute. They're vicious, but they're cute. But they're big. They're big creatures, right? Big fat creatures, big fluffy creatures. Hypotonic solution has lower solutes and more water or fluid. So you have more fluid to solute in the bag. So when it goes into the body, the hypotonic solution is going to come to the cell. And because it has low solutes and more water, osmotically, the cell intracellular is going to pull the fluid in, and it's going to take the cell and make the cell a big, fat, fluid-filled cell, just like a hippo. Right? It's a big fat cell. So that's hypotonic solution. It's going to have a lower osmolality, meaning lower solutes in the water, more fluid than solutes. And we need to be very careful. We give hypotonic solutions to cellular dehydration. So if I have a cell that's all shriveled up and dehydrated, I need to give fluids, right? I need to make it normal so we can have homeostasis. So if that's the case, then I'll give a hypotonic solution. The fluid will go back into the cell and make the cell normal. So we give it for cellular dehydration. And how or when do you see cellular dehydration? If you're hypernatremic, high sodium levels, your cells will be dehydrated. So we need to pull fluid back into the cell so we can create homeostasis. It can increase cranial pressure. And the reason why, think about this. If I'm going to make the swell fill with fluid, I can cause the cell to become big, right? So if I have increased cranial pressure and I'm pulling fluid into the cell, I can cause things to swell, right? Brain swelling. It's going to increase the cranial pressure even more, cause brain swelling, and we can cause detriment to our patient or client. So we would never give hypotonic solutions to an increased intracranial patient, or the risk of an increased intracranial patient due to brain swelling. The fluids for hypotonic, and I want to make sure I'm clear with this because I think I mistakenly said something a little different in class the other day, is half normal, 0.45%, 1/3 normal saline, 0.33%, and 1/4 normal saline are all hypotonic solutions. There's some others out there, but those are the three that I want you to know for right now. The next solution is hypertonic, and you need to think opposite of hypotonic. So if it's hypertonic, it's going to pull volume out of the cell. It's going to cause the cell to shrivel because it's pulling fluid out. It's going to cause it to shrink, right? We're shriveling it up. All the fluid is going from intracellular out to extracellular because hypertonic solution has higher solutes than water. So when we give it, what we're doing is it's floating, it comes to the cell and it says, oh, it's got higher sodium or solutes out here. Wherever salt is, water's going to follow. So it pulls it out of the cell. So with hypertonic solutions, we shrink the cells, and we like to, it has higher solutes, meaning it has a higher osmolality than the cell. So that's why we get that osmotic pull. It's an increased osmotic pressure. This is the fluids you should know are 3% normal saline, 5% normal saline, D10, and D50. Now, when we're looking at hypotonic and hypertonic solutions, there's things you should know. Hypotonic solutions, we need to infuse slowly. And the reason why is we want to prevent cellular edema. It's so important because if you give a high dose of hypotonic solution, a high fluid rate of hypotonic solution, what are we doing? We're pulling fluid into the cell. So what we can do is cause the fluid to go in so rapidly, we cause the cellular edema, and it can cause and reap havoc in our system, right? And we would worry about brain swelling and anything else. We don't want that to happen. Not for increased intracranial pressure. We do not give this. Ding, 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 star, 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 highlight, 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 whatever you want to do. Hypotonic solution, no for ICP, increased intracranial pressure. It will cause brain swelling and then cause a shift and can kill your patient, literally. It can cause hypovolemia, and I want you to just to think about this. I'm going to try to make it as simple as possible because it can get really confusing. If you have intracellular fluid in the cell, inside, ICF, intracellular fluid, and you have extracellular fluid that's all around the cell, it's out here. If I give hypotonic solution, I'm pulling fluid out of it from the extracellular fluid and pushing it, or osmotically it's pulling into the cell to make bigger cells. Because I'm pulling it out of that extracellular fluid, I can cause hypovolemia because it's not in that circulating piece, it's inside the cell. So it can cause hypovolemia. And one of the signs and symptoms that you should know for hypovolemia, if you see your patient and this happens, is tachycardia, right? There's not enough circulating volume, so we need to do something. So if you see someone receiving hypotonic solutions and they're tachycardic, you need to start to think that there is something going on at a cellular level, that we're pulling too much. We're creating hypovolemia at a cellular level. We're bringing it out of that extracellular fluid and into the cell. Hypertonic solution is used for hypovolemia. So if we have hypovolemia, we can give a hypertonic solution. If our cells have too much fluid, we can give that hypertonic solution and it can pull volume out of the cell into that extracellular fluid. So we use it for hypovolemia, we use it for heat exhaustion and peritonitis. But you want to give it slowly. Once again, anything with an osmotic pull, it's coming in or going out of that cell, we want to give it slowly because we can create major life-threatening issues by not giving it slowly. It can cause a mass with hypertonic solution. We can have a mass shift of fluid. We pull it all out into this from the cell and into the extracellular, and we can create fluid volume overload. And what are signs and symptoms of fluid volume overload for my students? Ding, ding, ding. Bounding pulses, JVD, increased blood pressure, crackles. If we're listening to the lung, we can back fluid up and create fluid overload and have crackles, and edema. So we have isotonic fluids equal, hypotonic fluids, lower osmolality, lower solutes, creates an osmotic pull fluid into the cell, making the cell big and fat like a hippo. And then hypertonic fluids pulling the fluid out, shriveling the cell. It shrinks the cell, pulling the fluid from intracellular to extracellular, and can cause fluid overload if we're not careful, if we do it too quickly. So that's a basic overview of isotonic, hypotonic, and hypertonic solutions. I hope this helps.